And the first question we would have is, what is community engagement and why is it actually important? And I would like to start with Innocent.
Yeah, thank you very much, Florian. And I think in simple terms, once again, I'm Innocent. I'm a family physician and I'm seated at Makerere University in Kampala, Uganda. So defining what community engagement is, I think in the simple terms, it is recognizing the critical role and the importance of communities in the planning, design, and implementation of health services. Therefore, basically, community engagement is working with the communities in making sure that the health system works out to meet the health needs. And how important it is, of course, we need to know that we are there as health providers to serve the communities, and therefore we need to listen to them. When we listen to them, that is the way how we shall know what they want and also be able to appreciate what they think. So the importance that I would just outline a few. One is that community engagement empowers the people, families, and individuals. It empowers people, individuals, families, and the communities. And we know that for us who are really focusing on primary health care, that kind of empowerment of individuals, families, and the communities is a key component of primary health care. Number two, the community engagement, it helps to promote ownership of the health services by the people. And because of this, it improves the utilization of the services. And then when we engage people, they are part and parcel and they actively participate in the conversation of the health services. Therefore, we promote person or people-centeredness in the provision of services. And as a result, because the people served will be at the center of the services, and we have listened to them. Therefore, it will promote satisfaction of the people that we serve with our services. And finally, community engagement helps us to understand the context within which our people live and work. And it will also help us to design the health services we provide appropriately, and also their implementation will be in a way acceptable to the people that we serve. Thank you very much, Florian. That is my understanding of community engagement and also what I think is the importance of community engagement.
Thank you a lot, Innocent. And I would now like to ask the same question to Amanda, of course.
Sure, thank you. Well, for me, in primary healthcare, I would echo a lot of what Innocent has said. We, in the UK, we have a geographical empanelment or registration. And so usually our community as a primary healthcare team will be the people who live near us. But in some systems, of course, you know, I'm thinking colleagues in Hong Kong, for example, people may register anywhere. So that community will be, in a sense, the patients of the clinic and may not be geographical. And then I noticed that WHO's definition says community engagement, a process of developing relationships that enables stakeholders to work together to address health-related issues and promote well-being. So actually, for some parts of an organization, the community might be quite high level. It might be politicians, it might be the public health department. And I live in a city called Norwich, which is not so big, but it's a city. And I think some community engagement initiatives would definitely be considered at the city population level, especially health campaigns. So which community is yours, I think depends what function you're doing. And then the question comes, and I think we'll return to this, about who engages how, for what purpose. But I think engagement, the other thing about that word, means it's a two-way dialogue. And particularly if you're dealing with people who don't feel very empowered in the system, the whole point of community engagement is to help them to have a voice in the system. So when I think about community engagement, I also think about that value-driven principle of empowerment. Thank you.
Thank you a lot for this excellent answer as usual. And I would now like to ask Asiya about the same question. What is community engagement for you and why is it important?
Thank you, Florian. Yeah, and I just want to build on the first two speakers, both Innocent and Amanda. And I think it's two small words, isn't it? Community and engagement. And then when they come together, they take on a completely different dynamics. And I think if we break them down and we look at who community is, we belong to many different kinds of communities. And I think that community is our smallest sort of form of organization of human societies. And so we are born into community. Our parents can be our first communities because that shapes our experience of who we are and our identity and our self-esteem and our place in the world. And then we go into school, and then school is another community that educates us into a certain way. And then there's the neighborhood community, the geographical area in which we live. And then when we move into a profession, we become socialized into being a certain way, depending on which professional community we belong to. And so I think within WHO, we've particularly been looking at how community means different things to different people. But I think it's really important that we have a broad definition of who community is. And speaking to Amanda's point, how those different communities engage with each other in order to form relationships that are trustworthy, respectful, and enable the kind of collaboration and shared decision-making that Innocent referred to in terms of in the design and delivery of healthcare services. So I think community engagement is a process. It's not something that is a moment in time outcome. It's continuously evolving. Depending on people's lived experience, the context in which various communities engage with each other change. And so it's a living process in which we need to be intentional about the way different communities that are interdependent engage with each other for a particular outcome. And it could be in the design and delivery of health services, it could be responding to emergencies, it could be designing a healthy city or a healthy school. But I think it's a process, definitely. And I think it's a profound one. And I think we'll get the opportunity to unpack that together.
Thank you a lot for this excellent response. And now I would like to ask Dheepa.
Thanks, Florian. And yeah, just like to build on the great responses we just heard. As Asiya said, really, it's a process. And I think that's why it's such a, it's one of the three key pillars of the Primary Healthcare Astana Declaration of 2018. Because without it, we can't have primary healthcare, proper a health system that really moves us towards better health and universal health coverage. What is community engagement? I mean, ultimately, it's about interaction and engagement of people, the public, communities, however we define it, civil society, stakeholders for purpose of steering the health system and supporting its implementation. And ultimately our goal, our collective goal is the co-production of health, even though in most places we're not really there yet. And, engaging with communities and with people it really, doing so shifts the way we look at health. Because at the moment, most places and most settings, the way the health system is organized is quite provider-centric, and in many places also hospital-centric. We heard the word intentional from Asiya and from others. The default health system in many places has moved towards the viewpoint that is not the viewpoint of people and of communities. And so in order to change that, we need to ensure, and in order to move towards something that is more co-producing of health, we need to engage with people and the public and communities and civil societies to see health more from the point of view of people, where we can see then that health goes beyond the biomedical, and that it's about health and well-being, preventive and promotive services. And I think theoretically we all know that, but in practice, to really get there, we need to engage with communities and really start seeing things from that point of view, seeing how communities experience health and the health system. And this is why it's important. This is why the co-production of health is our ultimate goal, because we want to improve population health and well-being. And really, one of the key pillars to get there, as expressed in Astana, is through community engagement. Because without health service organized around people's needs, we lose out on health systems performance, we lose out on health systems resilience. And I think this was really clear during the COVID-19 crisis, where all of our health systems, even in high-income countries, which are quite strong health systems in many ways, because the community engagement piece was not as strong as it could have been, still fared not as well as could be in terms of COVID-19 outcomes.
Thank you a lot for this excellent roundup of this first question. And now I would like to continue with the second question. When community engagement is important, what actually makes community engagement initiatives successful, and when are they not successful? When are they unsuccessful? So what is your definition of a successful or not successful community engagement, or which factors do you consider important? And I would like to start with Amanda.
Thank you. Well, personal perspective, I went into family medicine because I really wanted to help with prevention, early diagnosis. I was very interested in how people's lives affected their health. And so, one successful example, a group of us in a group of clinics started to employ workers who would advise people about health risks of their work, because we saw a lot of things from the factories and the mines, how people were getting ill in that place. And so I think successful community engagement, there are three things. One is the system has to be motivated to make it happen. That's what I meant about values. There are many parts of many health systems that are predominantly about money, reaching targets, quite utilitarian aims. And maybe, stopping smoking comes into that, but it's quite, not the main point of the organization. So you have to have the values that step above. Then the second is capacity. So Dheepa may have implied this, but even though the UK, seen as having a strong health system, predominantly my sector works with individuals. And there is nothing designed into my clinic which gives us the additional capacity for somebody to go and work with other stakeholders. Now that is changing when we come to examples. We're beginning to talk in some parts about community link workers or social prescribers, and I can talk more about those examples. But if the system doesn't have capacity designed in, then you're always arguing with your colleagues, should I be seeing patients? Should I be teaching the registrar? Should I be managing the team? Or should I be going to the community? Whereas if it's normal part of the role for one of the doctors to have some availability to go and meet with the community, with one of the other workers, whatever, you take my point. So first is motivation. The second is capacity. And then the third, I think, is the systems context, so reciprocity with stakeholders. So the community who are there, in a sense, as the word trust was used earlier, And we've seen some big issues around trust in authorities, again, in my country in recent times. And so even if I think it's a good idea, if people don't respect my clinic and the service we give them, if they don't trust us, why would they want us to have a discussion with them? And that could equally apply to another health provider or the local police force or the local gang leaders or whatever. We have to think. So I think building the relationships and genuinely doing the things that show that you are really trustworthy is the third part of that. And of course, in another way, we have a real advantage in primary healthcare because, you know, we are providing services, and if people like those, then if we come up with a new discussion, a new virus where people really have to change how they live, or a new vaccine, they're more likely to listen to us. So it's motivation, capacity, and the skill set, which includes, you know, winning trust.
Thank you a lot, Amanda. And yeah, I would like now to ask Deepa.
Yeah, just I'd like to, just build on what Amanda said. She mentioned system support, for example, for community engagement. I think that's a huge one, which it means that there's a political prioritization for working with communities and with people built in and embedded into the way the health systems work. So it's an underlying value, as she said as well. And this is not always a given. It's also linked to capacities in many ways, because a lot of the lack of system support is also because of a lack of understanding of, how it can actually be an added value to the system. And so, by bringing in, a big push for capacity building at all levels, so not only at the micro levels in terms of the providers and the patients, which of course is just as important, but also at, meso and macro levels, really build, doing a lot of capacity building to have a greater understanding of community engagement, and also training in the how and how to do it, because most people, working especially on the government side in the health space tend to have a medico-technical background. So the kind of soft skills needed to really engage with people and deal with conflicts of interest or interest groups, these are not the things that we were trained in usually. And so, there needs to be a big push in capacity building, and where capacities are higher, that is a factor of success. That's also linked to funding modalities and funding. So also linking to what Amanda said, you do need people either dedicated to doing this sort of work at the micro level with link workers or social prescribers, for example, or community health workers. So funding and resources. We did, sort of a back of the envelope calculation in a few countries to see how much does this cost. And just to make a very long story short, in relation to the huge amount of money that we spend in health, it was a very small amount. That isn't to say that you don't need adequate funding for, to do proper community engagement. You need adequate levels of funding. But what seems to be the most important thing when it comes to factors of success is that this is stable and predictable, even if it's maybe not huge levels, but if it's stable and predictable over a longer period of time, then, because what is community engagement? It's about building relationships. It's about building trust. And that's not something, if you just do one-off and the funding flow stops, even if it's a huge amount of funding, it's not very helpful. So you need stable and predictable funding at adequate levels, even if they're on the low side, at least if they're stable and predictable, and you know that you've got it for several years, you can really put that into building that trust and relationships. And that's what's going to give you the, the fabric that you need to work with communities to co-produce health. And it also gives you that resilience in hard times, for example, when something like COVID hits. So this is really, so I think capacities is really important, political prioritization, and stable and predictable funding. I would add a fourth issue, which is perhaps, secondary, but just as important, which is we need to learn more how to monitor and evaluate participation, because that feedback can help us improve. And at the moment, we, you know, that area is quite underdeveloped, you know, in terms of indicators, in terms of what we tend to monitor is the existence of participation rather than the quality of participation. And knowing and getting at that a little bit more helps us improve it. And by improving the quality of participation, we also, you know, improve the system as a whole and the relationships that we have between providers and communities and government, etc. So I think that's an important component that we need to invest a little bit more in.
Thank you a lot, Dheepa. And I have the feeling we could already write a paper about all your responses if we would just summarize. And yeah, and I would like to continue with the same question and now to Innocent before I will ask Asiya.
Yeah, thank you, Florian. Once again, just to build on what the other colleagues have said, there are just a few other issues that make community engagement successful. And I think, particularly for us from the African communities, what we have experienced is that communities are always receptive. They really want people to engage with them. And our experience shows that once you come with the right approach, then the communities play their role. And I want to look at the success of community engagement from our perspective, because we are there to make sure that people are healthy. And I think one key thing that we needed to appreciate if we are to engage communities is to acknowledge that communities have the ability to deal with their own problems. Therefore, we only come to support them. And there is also a lot of things we learn from these community engagement efforts. So we don't, so when we come, we need to have that perspective that we are going to run along with the communities, and that the communities have a lot of capacity to solve their problems. And then most times we really engage communities where sometimes in the cultures where we are not quite familiar. And therefore, communities, again, are the context experts, the community members. And therefore, as a person who is engaging the communities, you have to be flexible. How do you sail along the complexity that exists within the communities? We must make sure that we change according to what we find in there, because communities have existed over long periods of time. They have their ways of living, they have their ways of doing things, and you have not come to change, but you must make sure that the culture and the ways of living become synergistic with our community engagement efforts. And then we need to always appreciate that communities are complex systems. Therefore, there is no one simple way of getting things done. And therefore, we must appreciate this complexity, that there is no straight way to achieving what we need to achieve. And therefore, we must be able to read the patterns, appreciate the community functioning and the structures. And when we really blend along, then our initiatives will be successful. And I want to mention one of the community engagement activities we are involved in, trying to improve the performance of primary health care. In African communities, like in Uganda, where I am, people are in their gardens in the morning. Therefore, when you are to engage them, you must know what appropriate time should I engage in my engagement activities. And actually, we discovered that the best time is actually in the evenings. So if you just sit in your office and then you say, I'm going to meet the communities at 10 o'clock in the morning, be rest assured you will see nobody, and then your community engagement efforts will actually be dead on arrival. And I want to conclude by saying that one key thing that will actually lead to failure or unsuccessful, your initiative being unsuccessful, is when you come with the mind that I have actually come to solve your problems. You should come to work with the community in solving their problems. But when you come as if you are the alpha and the omega in dealing with the community's problems, chances are that your community engagement initiatives will not succeed. Thank you very much.
Thank you a lot, Innocent. And now I would like to ask Asiya to close this second round of the question, please.
Thank you. And I mean, you've got some really great responses already. So I think that the only reflections that I would add is that there are lots of examples of successful community engagement, and also lots of examples of when community engagement doesn't go well. And so we often don't hear about the successes because the successes don't really stand out. If the primary healthcare facilities functioning well, if communities are being provided the services that they need, things are happening. And so you don't notice when engagement is working because it's working. It's when it stops working that it becomes a problem. And I think that success really comes from what's already been touched upon, and that's the quality of the relationship. It's the interaction. Am I being listened to? Am I heard? Am I respected? Do my opinions matter? Do others care about me? And this is not just also from the provider to the patient. It's also looking at the interprofessional team, because the interprofessional team is an interprofessional community that is designing and providing services for people that need to use those services. So when we talk about success, we actually have many opportunities to learn how to do community engagement well if we look at all of the various communities in which we belong to or contribute to, and actually be intentional about how we show up in those relationships, and how, when we have responsibility to design processes of engagement, are those processes designed to create safe spaces for people that are coming together? Are there ways in which different people's voices and stakeholders are captured? How is that data used to inform then decisions around making changes that are needed? So it responds to the needs of people. So I think it is about understanding the culture in which the engagement is taking place, the various lived experiences of the communities that need to be engaged, and actually having the skill to be able to navigate relationships, because the different relationships require different things from us. And that there is a high level of awareness, because I think also the starting point for successful community engagement is myself. How am I being aware of how I am contributing and relating to the people that I come into contact with? And so I think that we need to be sort of looking at skills, awareness, context, and actually seeing the way that the current system functions, and as an opportunity to be able to shape and reshape the quality of the connections, the quality of the interactions that impact the quality of relationships between various stakeholders. And I do agree that it requires investments, and I agree that it requires a level of awareness and intention, because I think when we look at the unit of intervention for community engagement, it's the person, it's the people who are in relationship with each other. And so how are we helping people to be more aware of the quality of relationships that they're co-creating as they interact with each other?
Yeah, thank you a lot for this excellent closing of this question. And I would now like to continue with a question concerning concrete examples, because now we were talking about what community engagement is, why it's important, what makes it successful or not successful. And now my question is, which example do you have in mind, which might be very interesting, or which you just have in mind, or which makes a good story or has a good lesson, or which is just a good example of a successful or maybe not successful community engagement initiative? And is there someone who has already something in mind, or?
All right, so this is a bit of a classic example from our point of view. We bring it up a lot. But you know, Thailand is one of our star countries when it comes to community engagement, and a real emphasis sort of on primary healthcare, on community care. And you know, and they have a system called a National Health Assembly that happens every year in December. Actually, I had the privilege of evaluating the National Health Assembly process after 10 years, which is a publication that's online, and I'll put it into the chat box later if anyone is interested. But basically, this has been going on since 2007 formally, but it started 10 years prior in you know, without a legal framework around it. In 2007 there was a legal framework, and then since then it's a formal setup, and it happens every year in December. It's a like a 2 or 3 day event that happens in December. But the interesting thing is that this is prepared for a full year. So there's a whole year of preparations until the actual health assembly happens, and it's prepared by the National Health Commission Office, which is an independent public body, independent of the Ministry of Health, but it officially advises the Ministry of Health, but it's an independent public body with its own budget and Secretary General and a structure around it. And what they do is that they spend 1 year, first of all, trying to get topics for the Health Assembly, which goes through a participatory process of you know, anyone can make suggestions, but there are criteria for the suggestions. The proposals for the topics to be discussed in the Assembly to go through a resolution process have to have several different constituencies in support of it. So it has to have civil society behind it, academics, government actors, etc. And it has to be sort of fleshed out. And once and then there's a participatory process to select, you know, from the resolution proposals that come in. And then once there's a subset of resolution topics that have been decided that are going to be discussed in December, they form working groups around those different topics. And those working groups are also participatory, which include community groups, civil society, etc. And they spend the year then discussing these different topics to get it into a format that is presentable at the assembly, that can be discussed in this larger group, which National Health Assembly, which consists of really people from all walks of life and all kinds of constituencies. And then these resolutions are then tabled in December, and it goes through, you know, and then there's a resolution follow-up committee that looks at follow-up and links it to different policy institutions or departments that should follow up on these resolutions. The point is, though, is that there's this embedded process to bring in community and civil society and health professional voice into decision making, but also in implementation later on, because often some of the resolution implementation doesn't sit with government, it often sits with civil society depending on the topic. And so then there's an effort to work with civil society to implement some of these resolutions, depending on what makes sense and if it's a more of a local implementation, etc. Now, in terms of financing, and I'll end there to let everyone else speak, but so obviously this process has funding because the National Health Commission Office is funded, and they do have 90 people on staff. They do other things besides the National Health Assembly. They also spend a lot of time capacity building of not only civil society and community groups, but also of government cadres, because you know, when I was evaluating this process many years ago, you know, they said that some of our biggest obstacles are actually with government institutions, because they don't see the point. They don't see how this can actually help them. And so we have to spend a lot of time working with government to build awareness, build capacity, etc. So they spend a lot of time doing that. And in addition, just to say, you know, in this Thai landscape, there's also something called the health promotion fund, which is where the alcohol sin tax goes, and that also helps fund civil society, give core funding for civil society to help them, stay in operation and be operational over a longer period of time. Obviously, this is a very ideal case situation, and there's much more to this that I can tell you about. But just to say, to say that this is something that is really embedded in the way the health system works in Thailand. Over.
Thank you a lot for this really, really interesting example, which of course also other countries can steal and implement. And now I would like to ask Amanda the same question for an example.
Well, it is very interesting because Deepa's example is completely different from the three that I thought of. So that's good. In the chat, I've put 3 links to each of the things so people can read afterwards. But the ones that I thought of, we have something in the UK called the Deep End Initiative. And this started in Scotland, focusing on the challenges to family medicine practices, primary healthcare teams in very deprived areas, acknowledging that the health needs of the people there were much greater. Often the workforce was less strong, demands and the capacity and people not wanting to work there and so on. And so it didn't start with community engagement at all, but it did build into the model explicitly from the first stage the increasing capacity with community link workers so that the practices could work with those upstream issues about green spaces and lifestyle and public health and so on. And I think that whole, you can read about the Deep End stuff, it's rolled out to many other areas in the UK and actually into other countries now as well. But I think the principle of saying for a strong primary healthcare system, especially in a community where the social determinants of health are very challenging. And the second name I would log there, I haven't put it in the chat, but I can, is Sir Michael Marmot, who has done amazing analysis on that in this country and made it very clear that however hard doctors and nurses work in the community every day, we have to do things with government and with third sector and commercial side and the public themselves. So anyway, the fact that the Deep End Initiative, in order to strengthen the capacity of primary care, built community link workers in, I thought was really interesting. Then another example that goes right back to when I was a medical student is what you can do in your own place. Again, if you have the vision and the change and the process and the commitment over time. So the Bromley by Bow Health Centre, which started with a few GPs, nurses, people in the East End of London, again in a deprived area, has grown to this amazing initiative that is much bigger than just the clinic alone, that runs employment services, that runs, upskilling for people, digital health, whatever it is. And again, have a look on the website, but that in some GPs who've had the same lifetime career as me, it's just been the most amazing example of how real community engagement can lead to a real difference in a whole area of a city or a place. And I've seen many other examples of that kind of commitment around the world, although it's important that it penetrates the system as well, as Deepa was just saying. If it's one area, that's great for the people who are there, but what about everybody else? So, and then the third one was more pragmatic, but we already have a commitment in the NHS to patient participation groups. And often those are, it's people like I am now, older people who've retired, who've got the time, and they want their community services to go well, but it doesn't necessarily allow the people who are still working full time or have young children or caring dependents to participate. So the initiative to try and increase patient participation is a very important one. And there are different models to do that. We were talking, somebody said about skills and evaluation. I was thinking about Anne Macaulay's work in participative research and how she had the model of saying you need some public voices on your committees and your projects, but you also need to have an in-reach and outreach. So if you're going to do work with a particular community, like Innocent said, you've got to let them give their voice. You've got to let them take the lead on what matters to them and not give them a standard model that they've got to fit into. And our new initiative of social prescribing is meant to give us an increased capacity to work with people whose, as it were, whose health needs are a presenting factor because of their situational needs. And so rather than me just sit week after week feeling very sorry for somebody whose housing is bad, whose wage is poor, who's a victim of an abusive partner, I've got somebody else who can work with that person between me and the next time I see them to try and change the situation by helping them to engage with whatever it is, government agencies, victim support, lawyers, benefits, you know. So I think the three examples that I've given, the deep end, Bromley by Bow, and the move into social prescribing are just, you know, a few other bits from the UK that may help this situation, providing they're sustained. And again, as we said, you know, in 3 years' time, the money for social prescribing doesn't suddenly get taken away and all those things that happen. Thank you.
Thank you, Amanda, for these excellent examples, of course. And now I would like to ask Asiya for an example.
Yeah, thank you. I mean, they're all great examples, and I would have mentioned Bromley by Bow, and From too is another well-known example of best practice. And I think there are many other countries that have got great models of community engagement processes with significant impact and outcomes. I think the problem is, though, that when we look at the literature, how it was done is very rarely described, which is one of the strong points of the Bromley by Bow example. It's an extremely well documented model that had a strong research component that documented not only who and what was done, but also how those processes unfolded and what was learnt as a result of that. I think the example that I'd like to give is maybe I can touch upon the emergency context, and it was we were in the Ebola outbreak in West Africa. We were looking at a situation where there were high levels of distrust between the emergency response staff and the local communities, and the situation was so bad that it had resulted in the deaths of healthcare workers who were there to provide support and assistance to communities that were affected by the outbreak. And of course, Ebola is a disease which instantly makes people feel frightened because it's highly infectious, and it gets passed on through the very acts of giving care to people that you love and care about. And so what we wanted to do was really look at the interaction. I mean, we spoke about the relationship. So who are the communities that are in relationship with each other, and what's the entry point that we could have to really look at how we could improve trust between people who are affected by Ebola and those who are trying to respond. And so we focused on the surveillance function. And surveillance is not a natural entry point for community engagement, but I think in response to infectious diseases, and particularly in Ebola, because the surveillance officers are doing contact tracing every day for three weeks, monitoring symptoms in case people have symptoms of the Ebola virus. It was important to pay attention to particularly that quality of relationship. And so what we wanted to do was really focus on the lived experience of the surveillance officers themselves. Well, what was it they were struggling with? What was it about engagement that made it difficult for them to build trust? And so we looked at this whole area of fear and how when we're scared and fearful, you have an automatic response to moving to fight or flight. So it doesn't matter whatever the person in front of you is saying. If you don't trust them and if you're scared of them, you're not going to pay attention to what they say, and you're not going to process the information that they're giving you. So there's an inability to process information and prioritize information and then use that to make decisions about how to take care of yourself and your family. And so we designed a participatory training program for surveillance officers that also brought in Ebola survivors and people who were doing health promotion and health education to come together. And we actually looked at what drives fear responses. And I think also healthcare workers forget the physiology of fear responses. It's something that was taught in medical school or in nursing training, but yet the stuff that happens inside us and makes us do things that we rationally don't want to do is the stuff that actually we need to pay attention to, because when we feel, that's data that tells us that there's something happening that we need to pay attention to. And I think a lot of the research around fear responses and the way that human beings are primed to respond to look for danger is that every 7 seconds we are scanning. The amygdala is scanning the environment, saying, am I safe? Am I safe? Am I safe? And in emergencies, this hypervigilance, because the am I safe is no, you're not safe. And so then the responses, physiological responses kick in. And so what we did was really look with healthcare workers to understand what was happening, to then help them acquire the skills and the insights to be able to navigate the context and the situations that they were found extremely challenging. So this was dealing with conflict, dealing with parents who didn't want their family members to be taken away to the quarantine homes. And I think the biggest challenge that we had was that everybody thought that they knew what the content of that training was, but the content of that training was something completely different. It wasn't about messaging, it wasn't about providing information, it was equipping surveillance officers and responders with the awareness and the skills to be able to quieten their own emotions so that they could engage and create the environments that enabled people to also calm down internally, because there is this exchange of energy between people. And so it's the unseen part of the way that we detect emotions in other people. And then we layered that within the surveillance function. And at the end of it, these were skills that people used in their families, with their partners, with their children, because these are skills that are to build relationships with anybody. It doesn't matter who it is. And we had some really impactful stories of one family who had been working with a particular surveillance officer, and the woman was pregnant, and after she gave birth, she named the child after him because he had made such an impact on them. And it shifted the relationship to such an extent that the surveillance officers were paying out of their own pockets for telephone credits and other household items that the quarantined families needed, because there was a relationship there that they could nurture and cultivate. And the tools and resources that was developed for that in Sierra Leone can be made available as well. Thanks.
Thank you a lot for this really interesting response, of course. And now I would like to ask Innocent for an example.
Yeah, thank you very much. And I think before I give my example, I'm really listening to what Dr. Sia is mentioning, brings me back the memories of one of our senior family doctors here in Uganda, late Dr. Tai, who really was quite instrumental in the fight against Ebola, both here in Uganda and in West Africa. And I think in summary, I can say really community engagement in epidemics is driven by compassion, which I think is really the personal drive to relieve the suffering of others. And really thank you, Asiya, for mentioning that. That was quite a great example. I just want to give an example from Uganda here where I am. And I would like to mention that in many African countries, probably because of our weak systems, we do not have strong community engagement initiatives. But of course, different countries struggle in different ways to engage communities. For example, here in Uganda, it is by policy that every primary health care facility must have a health unit management committee, which is a committee that oversees the management of every primary health care facility. And this committee is constituted by members of staff of the facility, the health providers, both the support staff and the professional staff. And then they must have representation from the communities. So there are some community members who are selected to sit on these committees. And that is really the platform that community voices are brought into the planning and implementation of the health services, which I think in one way has worked excellently well, because when you are seated in the facility and you have community members being part of your management team, you will know what the problems are out there, and when you're planning, you actually put into consideration the context and what the needs of the people and what the voices of the people are saying. Of course, it has somehow worked, but I think it needs further strengthening so that more and more community voices can be heard. Of course, the other part of it is that these people who are members of the community and who are members of the community, but who are also part of this committee, they sometimes take it as a position of privilege. So instead of being there to represent the voices of the people, they actually take it as some kind of privileged position as members of the community. But I think apart from that, it has been an excellent way of engaging the communities in trying to listen to them and make sure that we become co-developers of health for themselves. Thank you so much.
Thank you a lot, Innocent. This was really a great end of this question. And we are actually almost running out of time, but I would still, if this is okay for the panelists, ask one final question. And the final question would be, how can we have more and better community engagement in primary care? So if there would be one thing you would like to change or one measure you would like to implement, what is the one thing you have in mind? And I would maybe like to ask again in an alphabetical order. And so I would like to ask again you, Innocent, if this is okay.
Thank you very much, Florian. And I think if I got the question right, you are asking what one thing would I like to change, probably in order to make community engagement better. Is that the question?
Yeah, yes. What is the one thing you would like to change to improve community engagement in primary care?
Yes, I think, as I said before, I want to re-echo that communities are complex systems. But the good way we know that there is no one straight way getting things done. But the good news is that these complex systems are adaptive, meaning that they can actually change if you allow them to change. And I think one community engagement, in my perspective, would really follow the theory of change, how we can change for the better. And there are really many things we can actually change in the training of health providers, we can change in the practice, we can change in the policy. But for me, one thing that I would change would really to promote community empowerment, where the community members have the relevant information and which will enable them to make good or proper health decisions for their own benefit. And how do we really promote community empowerment? We can do this, of course, one, through promotion of universal education, which has been a big problem, particularly in some low-developed countries like us, because when you go to engage communities, for example, they actually look at you as if you are bringing the benefit. Instead of say, I'm coming to work with you, they actually think you provide the solutions. So therefore, community empowerment would be the only thing I would really focus on in trying to change for the better. Thank you so much.
Thank you a lot. And now I would like to ask Amanda, please.
I'm still thinking, and the thing that I'm torn between is to give a very pragmatic answer, like to say, okay, the one thing I see is viable at the moment in the UK is to explicitly extend the social prescribing initiative, which I think has the risk of being very much again about individual patients with, albeit with social needs, but that's not the same model as community link workers who have the explicit aim of working with the different communities. And so we'll spend some time with community leaders and we'll think for primary care, okay, the young people, do the young people feel trusting and to come to the clinic? What are the barriers to them? Are they frightened? Their mother's friends will see them and ask why they're there, you know. So there's different communities. And if you have that capacity, it's different than saying this patient needs you to go and help them with their housing. So at one level, I would say if I could do one thing short term, it would be to evaluate, strengthen and support the development of the social prescribing capacity towards a more effective community engagement role, coupled with the capacity of at least one family doctor in each clinic. So you have the senior team as well to support that work. But then in another way, I hear Michael Marmot and I'm saying, you know, Florian, you know, if we really want to empower communities, we've got to give people jobs, you know, safety, capacity to, you know, work with their children effectively. I think Asiya or Dheepa mentioned early years exposure, you know, and stop the damage that social deprivation causes. And until then, in fact, you know, all our communities, when they do get a voice, will be saying, help. So I think there's the big picture politics, which we have to engage in as citizens, not just as doctors, health workers, whatever. And then there's the in my own space. And I think in the next 2 or 3 years, in my own space, I would want to increase the capacity in the primary healthcare team through and with the social prescribing initiative and to evaluate it and show in the process how it needs to be strengthened. Thank you.
Thank you a lot, Amanda, for this excellent response. And now I would like to ask Asiya.
Yeah, I'm going to steal other people's answers because I think they've given some good ones. I mean, to go back to the Ebola example, I think if you change a person, you change everything about what they do and who they are. So, and I take Amanda's point of if we build the capacities and the skills of the health and social care workforce to engage in respectful, compassionate ways to themselves and others, that is transformative potential there. And I think I speak on because we have to also look at the mandate of health and how health can actually lead the way in reorientating healthcare systems so that by the way that they function, they produce a public good. They are a global good. At the moment, they're not functioning in that way because there are significant challenges. We've got chronic work overload of healthcare staff. We've got senior healthcare staff leaving in multiple numbers post-COVID. There's a crisis in the workforce in many different countries. So the environment in which the health workforce is operating is incredibly challenging. And I think we need to take care of the people that take care of those that really benefit from having a health workforce that is resilient, that is able to operate in ways that they're able to integrate the social determinants within the design and delivery of healthcare. And I think we need to treat them as human beings and not as mechanisms to deliver support. And I think it's the trauma that the health workforce faces in going to work every single day and wondering, am I going to kill someone because there's not enough staff or because I'm not treated with respect or compassion? And yet I'm getting advice I need to be compassionate to people that come in for health services. I really think we need to prioritize. And so for me, the biggest thing that can make a difference is building relational skill, engagement, capacity, and compassion amongst leadership, program managers, clinicians, community health workers. Because if we do that for the health workforce, the system itself will change itself.
Thank you a lot for this fantastic response as well.
Well said, actually. Really good.
Yes, I agree, of course. And Dheepa, please, for the final comment.
Yeah, I don't want to keep people, but just to say, I think the one thing that we can do is really start training people differently. I think we need to train in our medical schools, nursing schools, physiotherapy schools. I mean, all of, a broad range of professions that work towards people's health. I think we need to start training them more in community engagement, also have them trained together to work collaboratively with communities, with each other, but also with communities. And so that starts to shift the paradigm, because at the moment we're all trained in a very biomedical way, and that's what we feel comfortable with. That's our comfort zone, and we need to broaden our comfort zone so that we feel comfortable, all of us working in health, working with communities.
Thank you a lot, Dheepa. And yeah, now I would like to thank all of you for this really, really amazing, very interesting debate on this very important topic. And